Good afternoon.
Good afternoon.
Thank you very much. I'm Alan Leshner. I'm the CEO here at AAAS and the executive publisher of our journal Science. And it's my great pleasure to welcome you and have the chance to moderate what should be a tremendous program this afternoon. It's part of a series that we do in partnership with the Dana Foundation on Neuroscience and Society. And as you can read, the title of today's session is The Aging Brain, What's New in Brain Research, Treatment, and Policy. I would like to recognize our colleagues from the Dana Foundation who are here, Ed Rover and his other colleagues. I won't try to identify all of them at once, but we are very grateful for their partnership in this enterprise that has been, as far as we can tell, a very productive partnership. I'll let them later speak for themselves about how they feel about it. But from our end, it's been a wonderful partnership. What we're going to do this afternoon is we're going to have three speakers, each of whom will speak relatively briefly. Hopefully, they'll stick to the schedule. And I'll just announce who they are all at once first, then they will come up one after another, and then I'll ask them to the three of them to come to the stage. We'll fix the lights so you'll be able to actually see them. We'll have them discuss amongst themselves for a little while, and then we'll open up to the audience. Those of you who have not been to a AAAS event recently, I'd like to just repeat the definition of a question. Questions are short. The people who will be at those microphones, you will be the questioners, they will be the speakers. And a question does not have a long preamble. It's usually a short phrase, and it ends with your voice going up at the end. So if you keep that in mind, I think it'll work very effectively. We really are very fortunate today because we have three outstanding experts to speak about the aging brain. The first speaker, their bios are in the program that you have, and if you promise not to be reading it while they're speaking, but maybe while we're in transition, you can read the details of who they are. I won't take their time by going into long introductions, but I will say the first speaker will be Marilyn Albert, who's the director of the Division of Cognitive Neuroscience in the Department of Neurology at Johns Hopkins University School of Medicine. She's also the director of the Johns Hopkins Alzheimer's Disease Research Center and a professor of neurology at Johns Hopkins. The second speaker will be Risa Sperling, the director of the Center for Alzheimer Research and Treatment at Brigham and Women's Hospital and the ADRC Neuroimaging Program at Massachusetts General Hospital, and she's an associate professor in neurology at Harvard Medical School. The third speaker will be my long-term friend and colleague, Dr. Richard Hodis, who is the director of the National Institute on Aging, the National Institutes of Health. He also is a leading immunologist and one of those few people in the world who has been very successful at simultaneously running a large NIH institute very well and maintaining an active and very productive laboratory. I've spent the last 15 or more years in high envy of his ability to multitask. So with that, we'll start with Dr. Marilyn Albert. You're on.
Well, it's a great pleasure to be here this afternoon and be part of this inaugural series on the brain and neuroscience and aging. Let me just... Okay, so as the first speaker in this series this afternoon, what I thought I would do would be to talk about normal changes in mental abilities with age, what we know about them, what we know about predictors of what allows us to maintain mental abilities with age, and then what the research is that's going on right now to give us some insight into potential interventions that might maximize successful aging. And then I'll sort of segue into changes in mental abilities that might be related to disease. And I believe my colleague Risa Sperling will then expand on that further. So the first question that we need to ask is whether or not there really are changes in mental abilities as people get older in the absence of disease. And the reason that I phrase it that way is that, of course, I'm sure you realize that as people get older, they all accumulate various diseases, and many of the diseases that are more common as people get older affect mental abilities. So when we want to understand whether or not there really are age-related changes in mental ability, we want to see if we can examine that in people or animals who are optimally healthy. So those are the kinds of studies that have been done over many decades, looking at individuals, humans and animals that are optimally healthy across the age range. And because I only have a very short time to speak to you this afternoon, I'm going to summarize them quite briefly. And I'm going to focus primarily on studies that have looked at memory, although in fact these studies have been done in other mental abilities as well. And when we talk about studying memory and changes in memory as people get older, what we really mean are changes in the ability to learn and retain new information. And part of the reason that I'm focusing on memory is not only because we're going to be talking later on about Alzheimer's disease, which is a disease that primarily affects the memory system early on, but because the area of memory has been studied extraordinarily extensively with respect to age-related changes. It's been looked at in humans and in non-human models, in individuals, in very large populations. We know an enormous amount about brain structure and function that's related to memory, and we also have some ideas about potential interventions that might maximize mental abilities, such as memory. The way we can sometimes study memory in the laboratory is to give people something very long to learn and try to remember. I'm not going to test you this afternoon, so you don't need to try to read these paragraphs, but these are the kinds of tests that we give people when we're in the laboratory. And the reason I put this up there is just to emphasize that when I'm talking about changes in mental ability, particularly memory with age, we're talking about the ability to learn and retain large amounts of information. This is really an awful lot of information. If I were to read you these two stories and ask you immediately what you remember about them, and then do something else for 20 minutes and ask you after a delay what you remember, you can imagine that that would be a very difficult task. And I tried that many years ago with subjects that I collected in Boston. And these were people ages 30 to 80. They were selected because they had no obvious, they had certainly no cognitive deficits, but they also were optimally healthy. So we screened them to have no high blood pressure, no diabetes, no chronic diseases really of any kind. And you can see the date on the slide. This was 1987, so I was a lot younger then than I am now. And I was nevertheless extraordinarily surprised and possibly disturbed by the data that we found. So you can tell by these stars up here that what we learned was that by the time people were middle-aged, they were beginning to have significant changes in their ability to learn and retain new information. And we were just astonished by that because we hadn't expected it. But since then, there have been numerous studies in humans that have confirmed these findings. And this is just an example of data from the Baltimore longitudinal study on aging. So the data I just showed you are cross-sectional, where we compare people at different ages and we say, how do these different age strata compare to one another? This slide represents data concerning change. So these are people who were followed over time, and the question was, how much did they change, and did they change significantly at certain ages? And as you can see from the slide, what was found was that by the time people were middle-aged, there were significant changes in their ability to learn and retain new information. Now, as I said, I don't have time to go into all the data on other model systems, but in fact, these same kinds of studies have been done in non-human primates, particularly rhesus monkeys, and in rodents, looking at animals optimally healthy, comparing them across the age range, and seeing when there are significant changes in age. And I would say that collectively, all of these data suggest that there are significant changes with age, and that that we can clearly see them in the absence of disease. So this is more or less the conceptual model that we have of age-related changes in cognition, where we feel that, in fact, there's some degree of change that is normal and that we anticipate would occur even in the best of circumstances. And that's different from people who are developing a progressive illness, which I'll talk about, and then Risa will talk about in more detail in a few minutes. So then the question is, are there things that we can do about this? I mean, I could talk about what we think is the hypothetical reason, and perhaps you might want to ask questions during the question and answer period about it, and I'd be happy to answer it. But obviously, we're not exceedingly happy to face being older and having cognitive changes with age. So are there some things that we can do in our day-to-day lifestyles that might be able to maximize mental abilities as we get older? And the way in which this has primarily been studied is in very large population studies. The original studies were done in people who were older, but now over the years there have been many studies looking at people starting in middle age. And they all have very much the same design. So this is taking very large populations, numbers of 3,000, 4,000 people, basically randomly selected, looking at a wide range of factors having to do with lifestyle at one point in time, being sure that people are, of course, cognitively normal when they're first observed, and then following them over time to see which of the many factors predict decline in cognitive function and which of the many factors predict successful function. And this is just an example of the many studies that have been conducted over the last 2 decades focused on this issue. I list them here primarily to make it clear that they're not just studies in the United States. You can see that some of them are in Canada and Sweden and Germany and the Netherlands, but they've all been focused on this same issue. Are there factors that we can identify that, if they are maintained, if they're maximized, lead to higher cognitive function? And I should perhaps point out that an awful lot of these studies were funded by the National Institute on Aging. So what we've learned is really something pretty straightforward. It turns out that there appear to be 4 factors that have been repeatedly found in these studies that are associated with maintenance of cognitive function. They're physical activity, mental activity, social engagement, and vascular risks. And the statistics suggest that these are additive in the sense that if you have 2 of these factors, then you're much more likely to maintain mental function than if you have just 1. If you have 3, you're even more likely, and so forth. And of course, this takes into account the whole aspect of genetics, which I can also talk about later. I should say that when these findings were first reported and it became clear that this is what was emerging from the literature, I don't think that anybody was terribly surprised about mental activity, but they were quite surprised about physical activity, and I'll say a few words about that. Vascular risks, of course, you know about, and these are having higher blood pressure, diabetes, cholesterol, having increased weight, being a smoker. It's not surprising, I don't think, that vascular risks, if you have a lot of them, it would alter cognition. We think that primarily this is because it affects small and large artery disease. There's perhaps disruption in the blood-brain barrier, perhaps increased inflammation and oxidative stress. And I mentioned this first in terms of discussing each of these issues because, of course, vascular risks we know something about. If you have these factors, it's extraordinarily important to try to control them. It really will make a difference in whether or not you have vascular cognitive decline. Physical activity was studied primarily initially by asking people about how physically active they were, how many blocks they walked, how often they climbed up and down stairs, in essence trying to get a sense of the amount of kilocalories people expended on a regular basis. And as I said, we were quite surprised about this. There were certain hypotheses that were formed at the time, and we now have some sense that it might be the case that when you're more physically active, there are certain trophic factors that are increased in the brain. But we don't know this for sure. And part of the problem with all of these studies, as I think you can gather, is that these are observational data. In other words, we're following people over time, we're seeing what things predict maintenance of cognitive function, but we can't get away from the fact that possibly there's something about an individual to begin with that altered these factors and made them present from the beginning. So the only way we can really determine if these factors are critically important in maintaining mental ability is by doing randomized, controlled clinical trials. And right now, there has not been a lot of that. And I'm just going to give you a few examples of what's been done. So with respect to physical activity, there have been some really extraordinarily nice studies, some of which have used imaging, and this is just an example. So in this particular example, one group were more physically active, another was the control group, and the colored regions in the brain show you where there was more increased activity in the brain in the people who were more physically active for about a 6-month period. So this gives you some sense that the physical activity is stimulating brain function in some way that we don't totally understand. And these kinds of studies have been repeated over and over again, but they're very small studies. And so what we really need is something much larger if we want to do a randomized controlled clinical trial. The way people have looked at mental activity with respect to randomized controlled clinical trials has been to try to do training. So the one study that I think is the most prominent, also funded by the National Institute on Aging, is called the ACTIVE study. That stands for Advanced Cognitive Training for Independent and Vital Elderly. And this involved about 3,000 individuals, and people were trained on 3 different cognitive tests: memory, reasoning, and speed. And the goal was to see whether or not that training would have an effect on day-to-day living and whether or not it would be maintained over time. And it was a randomized controlled clinical trial so that some people had this training and some did not. So the basic idea was that if you could train these cognitive abilities, that maybe ultimately, if you did a good enough job in altering brain function, that you could change daily activity. And this is the data from the 2-year outcomes from ACTIVE. And you can see that people got faster with the training and that speed was maintained on these particular tasks. But they also did better on reasoning, and reasoning was also maintained. And in fact, memory was also slightly maintained, although it was less well improved with the training tasks. Interestingly, 5 years later, there also appear to be some long-term benefits. So reasoning in particular was associated with less difficulty in daily activities 5 years later, when in fact the other kinds of training activities were not. The most interesting randomized controlled clinical trial that I thought I would like to just give you a sense of this afternoon is something called the Experience Core. This is something that I know about because it's going on in Baltimore, and it's really an unusually, I think, novel approach. So older individuals are being taken from the community. It happens that they're primarily from underserved areas in Baltimore. The older people are asked to volunteer in elementary schools, and they're asked to do this for 15 hours a week. they're reimbursed a very modest sum of money, and they're asked to do this for a full school year. And they do this in terms of teams, so they're trained to help children in school, and then they're followed over time. And this was originally done just to see whether or not, in fact, people who were older living in the community would feel better about being involved in these kinds of exposures. But what became clear was that their physical activity was increased, and perhaps you'd be surprised to see that their television watching was decreased. Now there is a randomized controlled clinical trial underway, and about 700 older individuals are being randomized, some of whom are participating in this program in the public schools and some of whom are not. And because of what we now know about the potential impacts on physical abilities and cognitive abilities, those things are being studied, and there are also some more intense studies looking at brain structure and function. So we don't know the answers to these questions yet, but we do have some intriguing ideas that being more mentally active and physically active and socially engaged and controlling vascular risk might actually make a difference in terms of maintenance of mental ability over time. So now let me just segue very, very briefly by way of introduction to Dr. Sperling about the diseases that are related to age, and particularly Alzheimer's disease, because it represents about 70% of dementia in older persons, either alone or in combination with other pathologies. There are different phases of the disease. We think of the transitional phase, where people are slowly beginning to develop mild impairment, as a stage called mild cognitive impairment. And this is where people have increased problems with recent memory, such as repeating stories and questions, forgetting conversations, having difficulty adapting to problems, but people are still able to function independently. And of course, what we mean is that all of this represents a change, because of course we all know people who repeat stories and questions all the time. Individuals of this sort might also have increased problems with judgment and problem solving, like having difficulty with handling money, handling emergencies, making decisions while driving. And this is the sort of conceptual framework that we have for this transitional phase, where here we have normal aging, but this mild cognitive impairment represents a greater degree of change over time than what we would expect would be normal. The symptoms of dementia are even greater than this. People have substantial problems with recent memory. They're constantly repeating questions. They're forgetting conversations day to day. They really cannot function independently because of this degree of impairment. And they have increased problems with judgment and problem solving. They need assistance handling money. They can't be depended to handle an emergency, and they have trouble understanding complicated explanations. So in total, we think of the fact that there is this normal aging, but there's this other trajectory that people follow, where first they have mild impairment that then progresses to dementia. So we don't know how to treat these conditions, but Dr. Sperling is going to teach us about how perhaps we can get better at it in the future.
Oh, I might need Bethany also here. I have a blue screen. Thanks. Well, thank you very much, and Marilyn, I'm vertically challenged, so I can't see you, but thank you very much for the great introduction. Let's see. Great. No, I'm a pesky Mac user, I think so. All right, terrific. Well, thank you so much. It's really an honor to be here, and especially to follow Marilyn. And I am really going to talk about the darker side of aging, which is that unfortunately, as we get older, that puts us at significant risk for developing Alzheimer's disease. And the title of my talk is really, can we detect Alzheimer's disease a decade before we get to dementia? And importantly, why would we want to? All right, so I will first disclose my relationships with industry. Sadly, none of them have anything to do with what I'm talking about today yet, but I hope they will in the future. And also acknowledge the funding, especially from the National Institutes of Aging, for some of the data I'll show you. So here's another version of that figure that Marilyn showed you. And I think it's been a very exciting time already because we've seen the field move from the stage of Alzheimer's disease that we all recognize clinically, that is at dementia, tremendous work over the past decade at this earlier prodromal stage or mild cognitive impairment stage due to Alzheimer's disease. But what I'm going to try to convince you of today is that there's very exciting research that suggests that the process of Alzheimer's disease has actually been going on in the brain 10 or even 20 years before we get to the stage of dementia. Now you might say, well, why do I think that's exciting? Well, because I think that's a chance someday that we'd be able to detect Alzheimer's disease before there are symptoms and prevent us from moving down this trajectory. Now, I think there's converging evidence, and I won't have time today to show you all of this, but from both individuals or families that have genetic risk for Alzheimer's disease, for apolipoprotein E4 families, and from age-at-risk cohorts, that the process of Alzheimer's disease, the pathophysiologic process, begins at least a decade before we get to the point of dementia, and maybe even a decade before we're at that stage of mild cognitive impairment. As I mentioned, I think this provides an incredible opportunity for us to think about intervention and ultimately think about preventing dementia rather than treating it or trying to stabilize it at that stage. I'm going to show you some evidence that I do believe we have good biomarkers and imaging methods now that allow us in life to detect evidence of Alzheimer's disease pathology. And I hope this will allow us to detect individuals at high risk for cognitive decline and ultimately to treat them and see if we can use these markers to help us determine if we're on the right road. So first, let me start with this idea of how we might detect asymptomatic Alzheimer's disease in the living brain. So this, I won't show you too much before dinner, but of course, these are the two hallmark pathologies of Alzheimer's disease. Many of you are probably quite familiar. Let's see if I can make this pointer work. Maybe not. The extracellular kind of rounded thing here, of course, is a extracellular plaque, collection of A beta 1 to 42. This, of course, is an extracellular collection of A beta, primarily A beta 1 to 42. A classic amyloid neuritic plaque. Of course, people in the field are arguing about whether it's the plaque or the soluble form of amyloid that really is neurotoxic. The other histopathologic hallmark of Alzheimer's disease are these tangles, which of course occur in neurons and are thought to be hyperphosphorylated forms of tau. I won't talk too much about this today, but I've said before, I think actually the field, we have to stop arguing about whether it's amyloid or tau, because clearly both are required to get to the stage of dementia due to Alzheimer's disease. And I think there's a lot we still don't understand exactly about how they interact and which comes first in the toxic pas de deux. All right, so one of the exciting advances in the field is the ability to look at some of these pathologies in vivo, and in particular, the ability to use PET amyloid imaging. This was developed in Pittsburgh by Bill Klunk and Chet Mathis, and they took that same, a very similar dye that would be used at that slide that I just showed you at autopsy after death, and figured out how to make a PET ligand so that we could look at fibrillar forms of A beta during life. And of course, this is the classic normal aging. where you don't have much amyloid deposition in cortical regions. All of this blue is nonspecific lipophilic binding. And this is a patient who really only has mild Alzheimer's disease dementia. So an MMSE of 26 was recently diagnosed, and already, unfortunately, you can see that they've got amyloid. In the yellow and the pink here are areas where you see high amyloid burden, fibrillar burden, or high PIB binding. And what you can see here are that this is all over the cortex, but particularly this area in the posterior medial cortices. And I'm going to come back to this region, the precuneus and posterior cingulate, because this is a region that I think is increasingly becoming evident that this is important for memory function. Now I'm going to show you some data from our Harvard Aging Brain Study using PIB-PET imaging. So the vast majority of Alzheimer's disease dementia patients are amyloid positive. Of course, this is a highly selected group because these are blue ribbon patients who come into our studies and are highly selected. There are limited data, I think, out in the community, but it does suggest that about 10 to 15% of people we call Alzheimer's disease dementia, in fact, don't have positive amyloid imaging or positive spinal fluid. And I think it remains to be seen whether these individuals were misdiagnosed or whether there's more Alzheimer's disease than we can detect with all of these biomarkers. At the stage of mild cognitive impairment, it's somewhat bimodal. You can see about 50-50, especially if you include early MCI. Individuals who are up at the range, you can already see in Alzheimer's disease dementia, and individuals who are called MCI but really don't have much amyloid deposition. And data both from many groups as well as the Alzheimer's Disease Neuroimaging Initiative suggests that the amyloid-positive mild cognitive impairment subjects have about a 5-fold higher likelihood of progression to Alzheimer's disease dementia over the course of 2 years using both spinal fluid or amyloid imaging studies. So it does seem to increase the risk within MCI of progression. But what I'm really going to highlight today and focus on is this normal group. And as you can see, here are a group of normal older individuals. We recruited blue ribbon normals, just like the folks Marilyn told you about, who were recruited because they're doing well cognitively. And we were a bit surprised about this, that about 32% of them already have a significant amount of amyloid plaque deposition, and importantly, they have it in exactly the same distribution that you can see later at the stage of Alzheimer's disease dementia, again in the cortex, highlighting here the posterior cingulate, but also frontal cortices. Now, just so you don't think that it's just that there's something about Harvard where all these people are walking around with a head full of amyloid, these are the data from several other large cohorts who've been collecting amyloid imaging, and they're exactly the same as we've seen with spinal fluid. So between 30 and 35% of healthy older individuals over the age of 65 already have evidence of amyloid accumulation. This is increased in ApoE4 carriers who are still normal, and maybe decreased in individuals who have other protective genetic risk factors. So the question I'm going to raise to you today, and I hope to convince you, is that we might be looking at evidence of preclinical Alzheimer's disease. And this is work from Chris Rowe from ABLE, the Australian group who's done tremendous work in amyloid imaging. Here is the prevalence of Alzheimer's disease dementia using an epidemiological sample. And as you well know, this is a very exponential curve. So 1 out of 10 individuals over the age of 65 are thought to have Alzheimer's dementia. Once you get to above age 85 or age 90, which is not so old anymore, it's up to 1 in 3 or 1 in 2 individuals have Alzheimer's disease dementia. This is the curve shown in green from 3 autopsy studies of the likelihood if you are healthy and you're cognitively intact, but you happen to be hit by a bus and died, and we got to get a chance to look at the brain. This is the likelihood of having amyloid plaques in your brain if you're normal, shown in green. And here I'm showing you in blue the likelihood of being amyloid positive on PIB-PET imaging. And this has now been replicated with other forms of amyloid imaging and spinal fluid. Now, of course, we don't yet know whether those individuals in the blue dots will in fact move forward over towards Alzheimer's disease dementia. But the current models suggest that it's about 15 years between the point that we can detect amyloid deposition and the point that we'd make an Alzheimer's disease dementia diagnosis. diagnosis. Now, importantly, we could wait 15 years, and we're all starting these longitudinal studies, but perhaps we can use other types of imaging and other biomarkers to get a sense about whether there are changes in the brain, functional and structural changes in these normal people that can tell us that whether they're on the road towards Alzheimer's disease, mild cognitive impairment, or dementia. So Bethany was worried that this was a PowerPoint malfunction, but it's actually a metaphorical black box, which is, I'm hopeful that I'm going to show you the way we've tried to include molecular and functional and structural imaging to help us illuminate the black box between the pathology that we can now measure in vivo and hopefully help us understand how that relates to the cognitive and behavioral syndrome that we all unfortunately know well at the stage of dementia. So I'm going to show you a little bit of functional MRI data, and I study how people remember names and faces, and this is because it's the most common complaint for older people when they come to see me. They're convinced that they have Alzheimer's disease because they can't remember people's names. But in fact, this is a very difficult memory task at any age. So who is this? Okay, very good. You guys are still awake at this time. That's excellent. All right, and it turns out that even in those 2 seconds that you were trying to learn a new association, whether it's between a face-name pair or other novel association, your brain worked in a very, very coordinated fashion to form that memory. And if you did it well, you'll actually remember it 30 minutes later or 24 hours later. And there seem to be 2 key regions in the brain that are critical for this successful memory encoding. So one, not surprisingly, is the hippocampus. Again, a classic memory organ, and both young and older subjects increase activity in their hippocampus when they learn something that they're going to remember well. So if you said that was Lenny and you're sure about it, your hippocampus turned on. But something that was very interesting to us, but there are also areas of the brain, some of you may know as the default network, that actually have to decrease their activity to successfully learn. And that was really all over in cognitive neuroscience for a long time point. But suddenly Alzheimer's disease scientists got very interested in this because it turns out that those default network regions, shown here, especially the posterior medial cortices, posterior cingulate, and precuneus, these are regions where amyloid deposits very early, even before there are any symptoms. So interestingly, we looked at high-performing older subjects and low-performing older subjects, all still within the normal range. And what we saw is that the high-performing older subjects looked just like young subjects in their ability to modulate activity. But the low-performing subjects, again, still within the normal range, but just the bottom half, had failure to modulate activity in that region. And we thought, maybe that's actually related to some percentage of them who might have early amyloid deposition. So this is work we did to follow up on that. We took a group of 35 normal older individuals, and we did both amyloid imaging and we did functional MRI. And we saw that their ability, again, to modulate this activity during the encoding of face-name pairs was impaired. Even though they could still do it pretty well, do the task reasonably well, they already showed functional changes. And these functional changes were occurring right up here, exactly where amyloid was depositing. The peak amount of amyloid in these normal older people exactly overlapped where they had this dysfunction. And we saw this, a very similar pattern to what we see in Alzheimer's disease dementia patients a decade later. Now, I won't have time to show you much genetic data, but this is some work where someone took our face-name task, took it down to Colombia, South America, with the PS1 kindred. I'm sure you heard about this exciting news a couple of weeks ago that they will start the first prevention trial in this large presenilin 1 kindred in Colombia. And they took this face-name task down there. They made Latino faces and Latino names, and they had 18 to 25-year-olds in that Colombian kindred, so 15 to 20 years before the average age of onset of cognitive symptoms in that cohort. And what they saw is exactly the same changes. So the asymptomatic mutation carriers already had changes in the posterior cingulate as well as in the hippocampus, again, 15 years before they have significant symptoms. And in these people, there's no question, unfortunately, whether they will progress to dementia because these mutations are 100% penetrant. Now this slide is Superman and his later years. And this one is to talk a little bit about cognitive reserve. So I'll talk about the bright side for a second, as Marilyn mentioned to you. And I think that there is some evidence that individuals who come to lectures like this at 5 o'clock at night, who are building up their cognitive reserve, actually do have some resilience to Alzheimer's disease pathology. This is work done by my colleague Doreen Rentz in our group, and she showed that individuals who had high education or high IQ actually could seem to be more at peace with their amyloid, or at least they didn't show evidence of memory deficits or other cognitive deficits, again, all within the normal range. Unfortunately, the people in the bottom tertile of education or IQ already did start to show a relationship between amyloid and memory function, even within the normal range. Now, it is possible, though, if you make a hard enough memory test, that you can overcome these effects of cognitive reserve. And this is some work she's done with this face name type task. And even normal older individuals who have amyloid already perform less well on that task than their amyloid negative peers. So I won't go into detail about all of these other studies, but there's been a tremendous amount of work in FDG PET, in structural volumetric MRI, as well as functional MRI, that really does suggest that the presence of amyloid accumulation in these normal individuals is associated with functional and structural alterations in a very specific network. And that network, we believe, is very critical for memory function. And I think this is exciting because it allows us now, I think, to make the link. Our basic science colleagues who've always been showing me evidence of long-term potentiation differences or dendritic spine morphology when they dump A beta on a cell prep. I actually think we can now see evidence of that at a systems level, a network level, using these imaging tools. So let me spend my last few minutes in talking about the most important question. So what? So why would I possibly want to find somebody, figure out that they might develop Alzheimer's disease in 10 years from now, and tell them if there's absolutely nothing I can do about it? Well, I want to make an argument, a strong argument, that I think this is the way we're going to do something about it. We've had 10 phase 3 trial failures in Alzheimer's disease over the past decade. I think this is not only disappointing, certainly for pharma and science, but terribly disappointing not only to scientists, but the families and the patients who've participated in these trials. I think that intervention before the stage of dementia, and importantly before there's the stage of irreversible brain loss, I think we'll have a better shot at really changing the course of the disease. There's a real public health impact reason to do this. I know Dr. Hodes will be talking about policy, but if we could just delay the onset of dementia by 5 years, we'd reduce the projected Medicare costs due to dementia by 50%. So we don't have to prevent it altogether. We just have to keep people alive long enough that they get to die in their sleep of something else. And importantly, I think we have to move in Alzheimer's disease to exactly where we've had successes in the rest of medicine. So think about what happens when we wait for symptoms in cancer, in stroke, or in cardiovascular disease, diabetes, osteoporosis, any of these diseases where we've really made a public health impact. We've done it by treating people before they get symptoms. So this has led to the idea that we really need to already start to think about moving towards prevention trials, even though we don't have all the answers yet. What we're doing now, and I think you're already seeing some, is what I'll call tertiary prevention, moving into the stage of prodromal AD or mild cognitive impairment, and seeing if we can actually delay or slow the progression towards dementia. Of course, we all want primary prevention. We want to find something safe enough to put in the drinking water of everybody over the age of 12, but I don't think we're there yet. Where I do think we're ready to begin is the secondary prevention trials, and trying to find individuals who either have genetic risk for Alzheimer's disease or have biomarker evidence that the disease has begun in their brain, but they don't yet have any symptoms, and see if we can slow the likelihood or decrease the likelihood or slow the progression towards cognitive impairment. Now, I work a lot on clinical trials in Alzheimer's disease, and this is a very nail-biting time in the field because several phase 3 trials at the stage of Alzheimer's disease dementia will report out this fall. I don't know any of the answers yet, but we will get some answers, I think, this fall. And I greatly hope that I'm wrong and that they're successful and that we treat patients who already have dementia and are able to flatten the slope. But even if we don't, if we have evidence that we actually are hitting our targets, meaning we are lowering a beta that we can see on our biomarkers and imaging, that we're changing downstream neurodegeneration in tau and the rates of brain shrinkage, I think we have to move earlier. There are several secondary prevention trials that are already beginning in these preclinical populations. The presenilin-1 Colombian kindred that we heard, the NIA will fund that trial. I hope will start later this year, actually, in the Alzheimer's Prevention Initiative. The Dominantly Inherited Alzheimer's Network is an international consortium also funded by the NIA, in which we look at presenilin-1, presenilin-2, and APP mutations, and we greatly hope to start clinical trials in that next year. But the one I think that's probably the most controversial, but I hope I'm the most excited about, that I hope will also begin next year, is something we call the A4 trial, the anti-amyloid treatment in asymptomatic AD. And this trial, I think, is important because these families who have very autosomal dominant, it's a very rare, that's less than 5% of all Alzheimer's disease. So these patients are very precious and will only get a few chances to do these prevention trials. Unfortunately, there's an unlimited supply of baby boomers turning age 65, and a third of them have Alzheimer's or have amyloid and are at risk for getting Alzheimer's disease. So we're proposing a trial where we will take these amyloid positive normal older individuals and we'll treat them for 3 years with an anti-amyloid agent and see whether we can slow the process of neurodegeneration and ultimately prevent cognitive decline. So who is this? Okay, I'm not worried about any of you. Excellent. Let me end by acknowledging the terrific group of people I get to work with at the Harvard Aging Brain Study, and also transition now to Dr. Richard Hodis, who's going to tell us about the policy of how we're going to really solve all of this at a public health level. Thank you very much.
Right, well, thank you. After hearing from Marilyn and from Reese about some of the exciting science, I'll try to put a little bit of context into the public health implications of aging brain, and do that with a few selected bits of information. I think, in general, many of you may be aware of what's happening with an aging population, but I've got some slides here that I think put it in what I think is a particularly dramatic way. So the curves you see on the left, superimposed on the globe, show the populations in green, age 65 and older, and in bluish, age under 5, as percentage of the population from 1950 through 2050. So you can see in 1950, and probably through the whole history of our species, they are, in this case, approaching something like 15% of the population under age 5, and only about 5% over 65. And the changes which you can see here are quite incredible, really. An increase in the percent over 65, a corresponding decrease in the percent under 5, so that somewhere in the current decade, for the first time in the history of the species, again, we'll see about an equal number of older, 65 and older, and younger, under 5. And you can see the projection of those curves that just keep on going, so that by 2050, we'll have essentially reversed the population distribution. The slide on the right in those bars just translates that into the percent increase we'll see in population from 2005 to 2030. So you can see the population under 64 worldwide is hardly going to increase at all. The population 65 plus will increase by about 100%, that is, it will double. Over 85 and more dramatic, and over 100, a 400% increase, or about a 5-fold population percentage numbers, age 100 and older before. If you think about what this means in terms of societal implications, it really means we're going to be living in a very different world as humans than we ever have before, and that we're going to have to find a way to have humans at older age have a quality of life, independence, productivity that's quite different from what we fear in worst case, and what might happen if we're not able to address problems such as those you've been hearing about in terms of cognition. To get an idea of how rapidly, again, these changes are occurring, this is an indication of how quickly, over history, populations in various countries have gone from a time in which 7% of the population was over 65 to the observed or projected time when that will double to have 14% over. So you can see that France went from about 1860 towards somewhere around 1980, maybe 120 years, to double the percentage of its population over 65. If you see how the countries that are aging now, particularly looking at the right at countries like Korea and Brazil, countries which are now increasing their age of population at a much accelerated rate. So rather than taking 100 years or a century to have a population change, this is happening in 10 or 20 years. Again, emphasizing the pace and the urgency at which we come up with ways in which we're going to address medically, societally, what's going on. This is an interesting slide, I think, that illustrates the way in which population aging life expectancy has progressed over time. So this plots from 1840 through the present, shown here 1840 through 1920, the first 80 years, the age of women in the country who had the greatest longevity at that point in time. And the country changes, and that's the symbol. So you can see down at 1840, it was the Swedes, where women were living to age 45. That was the record holder at that time. And you can see that, for example, New Zealand, through those years approaching 1920, was the record holder. But what's quite remarkable, I think, to scientists, statisticians, people who are thinking about it, is how linear this is. That there's a curve, a line here with a slope of about 1/4. So every 4 years, life expectancy goes up by 1 year. And I wonder if we'd been sitting here in this auditorium, had it existed in 1920, and asked what the probability was that a curve like this could possibly go on for an additional 80 years, I think I probably would have voted against, but this is in fact the curve. And you can see now it is Japan in those years towards the top. This means now for 160 years there's been a linear increase at this slope of 1/4. Every 4 years, 1 year, every hour you spend in a lecture, your life expectancy goes up by 15 minutes, right? But again, I'd ask the same question. So how many people now, having been sobered by this curve, would expect, for those of you who can come back 80 years from now, if we're going to have increased life expectancy by another 20 years? And there's no end to speculation, as you know, those people who think that life expectancy is essentially unlimited and infinite to those who have more modest expectations. But this, I think, is quite a dramatic illustration of what's been going on this planet over the past century and more. In addition to life expectancy, there's also been, and continues to be, a developing change in the kinds of maladies or diseases that we face. So this is an illustration on the top, low and middle income countries, and the bottom, the high income countries, in the proportion of disease that's caused by, in the blue or larger portion of the pie, you'll see this illustrates the non-communicable diseases, generally chronic, as opposed to injuries and more communicable diseases. And you can see that, not surprisingly perhaps, that in the high-income countries, the proportion of chronic, non-communicable diseases is high, and from the year 2002 to 2030 is only going to increase a bit. But note, the middle-income countries, the trend is going to increase, so they become more and more like the developed world, and it is the chronic diseases and certainly the neurodegenerative diseases that are among them. So not only are people aging, but the nature of diseases with which they're encumbered is changing to be the more chronic diseases, as in fact we have are the product of success in treating many of the acute, treatable, infectious, and other diseases. In terms of disability, again, how many of us would want to live an extra 10 or 20 years is very much dependent upon the quality of that life. So this was one of the more optimistic findings that emerged over the past years, and unfortunately I'll have to qualify it once we've been through this slide, but it was carried out by looking in the National Long-Term Care Survey from 1982 through 1999, surveying people in that study for the proportion and the numbers who were disabled, defined by a number of compromises in their activities of daily living. And you can see there are two lines here. So the red and blue lines begin at the same place in 1982, when there were some 6.4 million Americans aged 65 and older who were disabled. The upper curve is the projection of what would have happened as the population aged if the same likelihood of disability for each age had continued. So because the population was aging, there was projected to be this kind of increase from 6.4 to 10 million Americans disabled. The very exciting and heartening news, in fact, is that shown in red, this is the actual observation. So people were not becoming disabled at the same rate as they had. This is really quite an extraordinary change. Actually, from 10 million expected to 7.4 is a 26% decrease in the expected degree of disability and certainly proved the point that disability was not inevitable. It challenged us to understand why we were having this impact over time. Changes in education, changes in public health are likely to be among them. But it does emphasize that there's reason to be trying to intervene, that nothing is immutable about disability and aging. But I have to point out here, in addition to the possibility that interventions might work to advantage, we are very sadly seeing that disability rates are now rising in young, and by young I mean younger, even the baby boomers who are approaching old age, in part perhaps due to trends such as obesity and related disability, but where we've seen some very exciting and positive trends in the past couple of decades, we really appear to be on the verge, just as we have more and more aging individuals, of seeing that reversed by clearly modifiable lifestyle changes. So as we talk about policy and the ways in which policy can have an effect on what we do, this is an interesting study that was reported back in 2007, and it looked at the effect of retirement age on cognitive function. Now, as you heard pointed out, observational studies are difficult because one doesn't often know what cause and effect is. So if we were to tell you that people who retire early tend to have poor cognitive function, hard to know whether their cognitive function is poor because they retired or they retired because somehow they were sensing their cognition was not all it should be. But in this study, what was done was to look at international comparisons. So varying countries, largely Europe, Japan, and the United States, have policies which encourage to varying degrees retirement. So if a national policy provides great compensation at an early age if you retire, so it may not even pay or it may be a disadvantage to continue work, that will tend to encourage people to retire early, and it appears unlikely that national policies would be influenced by national differences in cognition, although I suppose one can hold that as a possibility. But if you exclude that, what this slide says is shown here. So those countries that have early retirement because their national policies encourage it, France at an extreme, will tend to have, in the period for men from age 50 to 54 until 60 to 64, so in this 10-year period, the cognitive decline in those men, and this is a graph, so down is more cognitive decline in those countries where retirement by national policy is encouraged to be earlier, less cognitive decline in countries like the United States where policy and financial incentives appear to discourage early retirement. Now, if one accepts that this may be causal, it certainly is in terms of policy and the ability which we can be rational in our policies, an argument for considering just what we do when we encourage or discourage people to remain active in a workforce for a longer period of time. In order to understand, this is related to the previous slide, really how much of an impact we can have by changing national policy, this shows for a similar range of countries, if you set your public pension incentive, as economists would relate it, to either favor early retirement, that's high encouragement to retirement, or low discouragement, you can see that the distribution of curves here very much parallel what we saw before. So just those countries whose policies encourage early retirement have early retirement, and by correlate show a far greater decline in cognitive function in those people who in fact follow the encouragement of their policy and retire early. Something to keep in mind. So in terms of things that are going on now, legislation and activities that are attempting to address some of these issues in our own country, in the annual wellness visit, which is now required by CMS for compensation under one component of the Affordable Care Act, there is a requirement for including measures that will detect cognitive impairment. Now, this means for the first time there, if all of this legislation should sustain itself to the Supreme Court and other judgments, and that there will be an opportunity for assessing a large number of individuals for their cognitive function. There is both a lot of optimism about the fact this may allow the kind of early diagnosis of problems that we've talked about. There's also a concern that if we screen everyone, we're going to find a lot of people, perhaps even by false positives, for a disorder or problem, who are then going to be subject to very complex distressing and expensive diagnostic procedures. But what we recognized when we saw this legislation come through is, what does it mean that the examination has to include some effort at detecting cognitive impairment? There, in fact, is no consensus by any means, not even any requirement in legislation, for there to be a test of some demonstrated ability or competence in order to accomplish this. So what we've been doing is to work with we, NIA, and federal agencies to in fact, work with a number of organizations at assessing so far some 140 competing instruments that have to be doable in less than 5 minutes. They have to be free because nobody's going to pay to administer them, and they have to have sufficient power and specificity to be acceptable. And we'll be making recommendations to CMS in these next months, no recommendation being the worst we can do in a case when this is going to happen, we feel. So there may be very well a real change in approach where no longer is it only people who have recognized problems who are going to become forward for screening, but we may be doing screening the way we do for cholesterol or blood pressure at a very earlier time. And it remains to be seen what we'll be able to do with this information. Just as you heard, we're going to feel very differently if all we can do is tell people they better be careful and continue exercising, or if we really have an intervention that can help. And we hope, of course, it's going to be the latter. Alzheimer's disease itself, you've heard about how important an issue this is. Just to illustrate why and tie it to what I showed you about population, clearly the greatest risk factor still that we understand it for Alzheimer's disease is age. And this is an illustration of one of the earliest epidemiologic studies done in East Boston back in 1989. In this study, some 3% of people aged 65 to 74 had a diagnosis of Alzheimer's disease, 19% 75 to 84, and 85 and over, nearly half. Given this, if nothing were to change, and if what I showed you about the change in our aging profile would occur, this is the projection for increase in the number of individuals with Alzheimer's disease, where estimates now range from 2.7 to 5.3 million or so, to some 3 times that or so by 2050, simply because the population is aging. And the burden of human suffering above all, but also financial and on our medical system, is just enormous in this circumstance. And in recognition of that, a great deal of advocacy led last year to the passage of the National Alzheimer's Project Act. And it requires a number of things, requires largely of the Secretary of DHHS that to be a plan, and a very comprehensive plan. And I'll talk to you just a little bit more in these last minutes about what some aspects of the plan are, to address many aspects of Alzheimer's, ranging from research to support. Towards this goal, and is one of the components of the implementation of the plan, we convened at NIH with the help of a good number of public and private sector sponsors, a research summit just on the 14th and 15th of May. Some of you were there, but it brought together an audience of some 500, is the largest venue we have on the NIH campus, of experts to discuss priorities in the area of aging research and identify what is most critical in our path towards moving from what we understand about basic science to its translation. The summit was notable for its attendance in person as well as by webcast. It was national and international. Secretary Kathleen Sebelius came, and at the occasion of that meeting presented the first national plan, and I'll talk to you a little bit more about what was in that. At the same time, Francis Collins, the NIH director, was there and announced some of the clinical trials which have been newly funded, and you heard alluded to, all in context of some additional funding that was made available for Alzheimer's research. I will point you only to a web link for those who are interested in great detail about what the nature is of recommendations from the summit, but they ranged from interdisciplinary approaches to discovering the basic molecular and cellular causes of disease, to challenges in preclinical therapy development, and on through therapeutics, non-pharmacological interventions, and new models for public-private partnerships. The plan itself, which is the last bit of policy I'll talk to you about, and was released and certainly available to all of you online at the address noted here, had 5 goals in total, and I point out that just the first of them is one we've really been emphasizing to date, the efforts through research to prevent and effectively treat Alzheimer's disease by 2025. Great deal of controversy in picking any date at all because we don't really know the way we can in certain engineering tests just when we're going to succeed. But I think we largely accept this date as an aspirational one, and it certainly provides plenty of impetus for us to move as rapidly as we can towards execution to that goal. But in addition, in the meantime, the need to enhance care, quality, and efficiency in taking care of those affected and their families. Expanding support for those with Alzheimer's, again, and families, enhancing public awareness and engagement, both participation in research and collaboration in a national effort that's going to take the will of not just federal partners, but private sector, national, international participants, and then improving the data we need that will allow us to track progress towards what we hope will ultimately be achieving the goals that we set out for ourselves. So those are some aspects of the policy that relates to aging, what is happening in an unprecedented way to humans on the species on this planet, and how imperative it is that we find ways to improve the quality of life for what's going to be an unprecedented population, older, with huge potential, if we can salvage from ourselves and our predecessors quality of life that will accompany the increasing longevity that we see. I thank you and look forward to talking to you.
Fabulous. These were really terrific presentations, I have to say. That was really great. So I think what we'll do is I'll give them a couple of minutes to have at each other if they have something pressing that they'd like to ask each other. And then we'll open up the microphones and see what kind of questions you have. What I will ask you to do when that time comes is line up at the microphones, say who you are, and ask your question briefly, remembering the rule of questions. Okay. Anything any of you want to say to the other, amplify what somebody else said, correct what they said, we'll enjoy that. Anything pressing? Go ahead. Risa, you have that look.
So I'm very
working.
interested in some of the ideas that Marilyn brought up about, how do we augment successful aging and exercise and cognitive activity. And I wondered whether you think that will be different in people who have preclinical Alzheimer's disease or this idea that they have pathology already versus people who don't, and whether that would be useful to look at the biomarkers and see whether there's an interaction between the intervention and the underlying pathology.
I think we can take a guess that it would be different, primarily because of what we know from the active study. So the active study was done in people who were cognitively normal, but there was a subset that had mild impairment. And in those people, the interventions didn't seem to be as effective. That just gives us a hint that if people had pathology, it probably would be a different outcome. And that's what makes me think it's so important for people to begin making these changes in middle age. I mean, I was going to ask you, Richard, it really looks as if we have to begin earlier. And I was wondering if the NIA is funding a lot of studies in middle age, because that really seems to be the time when at least lifestyle changes might be able to make a difference.
So it's a great question, and you'll probably hear some spectrum of thoughts and thoughtfulness across the group. The lifestyle changes, lifestyle associations with risk are very well demonstrated, as you point out, in epidemiologic studies. But as you also commented, there are associations, and in fact, to the dismay of some, there was, after a State of the Science conference that NIH sponsored a couple of years ago now, the conclusion that, in fact, there was not a high level of evidence in the way that these evaluations go to draw the conclusion that any of these lifestyle interventions can or would decrease the probability of dementia. Mm-hmm. So that leaves us with a lot of suggestive evidence and having to make recommendations on the one hand and design research, if we can, on the other, to be even more rigorous in the approach. So maybe dealing with the latter first. What can we do to make the evidence of higher quality than it exists now? I think most would sense that More association studies are perhaps useful, but are not going to be definitive. We already have great associations. So what other kinds of evidence are there? Well, there's biological credibility and mechanism, and we didn't dwell on it among the three of us, but are aware of certainly a good deal of evidence that show that an intervention like exercise or challenging environments of one sort or another in animal models do things like increase the generation of new brain cells, pretty compatible with the notion that lifestyle is associated with protection. There are also short-term studies, as was commented, and they are short-term, that's showing that physical activity can improve cognitive function, and that's paralleled by demonstrable changes in the brain. So we know that these things in short-term and animal models and by association can occur and indicate ways in which we think we can protect ourselves. So if we have to make a choice today, I think what you're hearing is all of us would say, even if we're saying the evidence isn't perfect, and we can't say we have conclusively identified causality and therefore don't need to do any more work, making no recommendation itself is a recommendation, and all of us would probably say that we should go forward acting on what we know. But what about clinical studies? What can we really do? The ideal study would be what? We take a group of people, we would randomize them, let's make it multi-intervention. You will exercise, you will maintain a good body weight, you'll control your blood pressure and your cholesterol, and this other group won't do any of those things. And you'll start this maybe when you're 25 or 30, and we'll follow you for 30 or 40 years, and we'll see what happens. That would be a definitive study, which of course will never occur. But to point out, there are ways in which we are doing as close to that as we can. So, for example, in terms of cardiovascular risk factors, where we've had the best opportunities, other institutes at NIH, NHLBI, not surprisingly, has carried out longitudinal studies that have looked at or looking at the effect of controlling blood pressure and/or glucose levels in individuals at varying ages. And by supplementing those studies, by support from NIA and other institutes, we now do cognitive function and brain imaging, and we will have answers in studies that look at 5 or 10-year follow-up at whether we can see changes in those parameters as a result of controlling cardiovascular risk factors. In terms of exercise, there are for the first time, surprisingly, some large-scale exercise interventions being supported by NIA, initially designed for primary endpoints like disability, mobility disability, but also now have cognitive measures. So depending upon the power, the nature of the effect, we actually have the potential in some of these studies to see dramatic effects on cognition if they are there. So when we have the opportunity, sorry for the long answer, we need to increase the level of confidence, the quality of evidence, while at the same time we need to, practically speaking, act on the evidence we have at hand in terms of recommendations to the public.
So let me ask a question, and then we'll open it to the crowd. So are we at a point, or are we nearly at a point, where we should be mounting a public health campaign that says, you middle-aged people, just like we tell them, exercise and watch what you eat to prevent diabetes or obesity, deal with their heart conditions, when are we confident enough in interventions that we would start advocating that people in middle age or in cognitive impairment start changing their behavior? Was that clear?
Yeah.
Did your voice go up at the end?
A little bit, sort of. Yeah.
Well, you'll get 3 answers, but and they may or may not be the same, but I have a sense that often, as speaking for at NIH, we tend and maybe have responsibility to be the most conservative. So you're asking me if I think that we have definitive evidence that people should do all of the right things that you mentioned because we know that will decrease the probability of Alzheimer's disease. I say we are short of that. But I think what, in my own perspective, is easier to say is that there are so many indications that these lifestyle changes will improve survival, cardiovascular risk, all-cause mortality, and there is evidence to suggest that they might also have advantage for cognitive function and decrease risk of dementia. That language is about where I'm at, but others, frankly, have been much more forthcoming and definitive and say that we know enough, we don't need any more research, we can be definite. And it is a matter of judging level of certainty, but I would value the judgment of my colleagues.
Well, I very much agree with you. I think that there's already clear evidence that it would have an impact in cardiovascular. So I feel like we already have the evidence that these lifestyle factors in midlife would be useful. Where I actually think we need some research is how do we implement it? Why is it that since we already know it would be good for us, even if we don't yet know whether it'll prevent Alzheimer's disease, are we all couch potatoes? Not all of us, you. But so I think we need actual research to say what would it take to really implement this, and what would make not only would make people want to do it, but how do we actually get them to do it for 10 or 20 years, which is what's probably really needed to reduce risk in Alzheimer's disease.
Marilyn?
So to some degree, that's why I was mentioning the experience core, because I think what the answer for each person is different. It has to be something that you like to do. And one of the things that the experience core teaches us is that the people engaged in this program loved doing it. They were valued by the community, and it also was good for their health, and it appears to have been good for their cognition. So I don't think there's a single answer, but I do think that we have to find sort of these kinds of programs that would have multiple effects on cognition, but also be very enjoyable.
Yeah, and just expanding on that, it's likely the solution, again, is going to be very much a multi-level one, so that built environments are going to have to make it easier and even pleasurable for people to walk, not drive. Having access to the foods which everybody should eat because they're healthier has to be provided. So in addition to studies which NIH is supporting, actually trying to understand behavior change and how people are motivated, it's likely we're going to have to look much more broadly than just what the doctor can do, what public service announcements are going to do, and look at ways to modify the environment in which we behave.
Mm-hmm. Okay, so these are going to be the set of questions. Nobody else get up to the microphone, because otherwise, short questions, short answers. There's an ancient adage, never get between people in the reception, so I'm going to try not to do that. You first, you second, and then the line. Go ahead.
Türkan Gardiner from Pragmatica Corporation. Relative to the three titles, research, treatment, and policy, I have an observation that at the county level and local levels, there's a lot of work and effort going on in disseminating the research to the elderly. However, the information that I have about funding is that universities apply for funding. Do you have mechanisms for local groups to get funding from NIH, for example, for dissemination and actual practice of the findings?
So NIH, including NIA, have a very strong responsibility to disseminate information. And we do work very closely with organizations, with foundations, any and all, to help in information dissemination. That generally is not in the form of grants or funding, but it's working with those organizations to provide speakers, resource access. In that regard, there's a good deal of outreach. There also is an opportunity for many organizations and foundations to work with academic partners in proposing research or demonstration projects by which implementation can occur. So, for example, the clinical trial you heard described, ACTIVE, which showed that there are ways in which cognitive changing can make a difference. How do we disseminate that? So there's research, including support of private companies, academics, organizations, to see how we can translate some of these demonstrable activities to implementation in a broader community.
Good. Please.
Thank you. Mike Miller. Since we are going to be heading into reception, I wondered if you could extend some of the lifestyle benefit changes you talked about to include modest, minimal alcohol consumption, which has been shown to have other physiological benefits.
Yes, so the data, as you suggest, indicates that modest alcohol is good for you. Modest alcohol.
Don't get your hopes up. There isn't going to be that much.
But does it have benefits for cognition, preventing dementia, memory, as well as cardiovascular?
We think that the benefits are via cardiovascular effects, but we don't really know.
We can't remember. Thank you. Please.
Okay, to Dr. Sperling, most of your work was done on brain scans, most other areas of biology are showing changes within the cells. When do you think this research is going to reach that? And to Dr. Hodes, you're an immunologist. Do you think there will ever be an immunological treatment for Alzheimer's?
Yeah, Richard.
Let me let him answer that one first. And in fact, I had that same question for you. Is inflammation a good thing or a bad thing in aging?
Yes. Well, to Reese's question, there's been quite a bit of data lately that's emphasizing the fact that with age, and in fact with aging with disability, there are many signs of increased inflammation. So there are certain kinds of inflammation that probably can be bad. On the other hand, we all recognize that an immune response to certain challenges is an important and good thing. And some of the changes that accompany aging involve a poor response to certain challenges. So it's not going to be as simple as is inflammation or the immune response good or bad. It clearly is the right kind of response and where. In terms of experiments that people are maybe aware of, there are suggestions that inflammation is occurring in and around the kinds of lesions you saw in the brains of those with Alzheimer's disease. And that's raised questions about whether suppression of that kind of activity could be a good thing. There's also a question about whether using an immune approach to immunize against, if you will, just in the simplest sense, things like amyloid might make a difference. There are animal studies that are very, very impressive, I would say. You can use immune treatment of a mouse that has the human amyloid-causing, Alzheimer's causing amyloid gene, and you can cure that mouse of a large part of its amyloid burden and make its cognitive function better. When that study was taken to humans, there were side effects that were intolerable, and so the study stopped. But there are other variations of that kind of approach which are still ongoing, and I think they are reasonable, they're logical, they work in animal models, and it remains to be seen whether they'll work in humans. So it still is one of the viable, I think, mechanisms that might be addressable in terms of pathology. And
Risa, do you want to say something about cells?
Right. So I actually believe that Alzheimer's disease is fundamentally a disease of synaptic failure. So that's a cellular function. And, I live in amyloid land. Amyloid is largely extracellular, but its thought is that it has effects within cells. And clearly we need to work on all of the cellular changes that occur that I think underlie synaptic failure and ultimately neuronal death. What excites me, though, is that we can now see with imaging, I think, at least an analog to what my colleagues in basic science tell me are going on in the cells, meaning they dump A beta on, the cells look unhappy. We can see that at a systems level now that I think might allow us to translate this into monitoring therapy, immune therapy, in a way that we couldn't do before.
Okay.
Dr. Melendez, Dr. Hodes, I think you showed the figure of the peak age growth for females, and I'm wondering what does that look like for males if you plot it over, and if there's a difference, what's that about, and maybe what policy implications it may have?
I honestly have not seen the data plotted for males. I would strongly presume it will look the same but be shifted down a bit, in that the male-female difference has been consistent in essentially every population study that I'm aware of. When people have factored the differences in most parts of the world, it's due to a difference in cardiovascular disease and age of onset. Interestingly, as it relates to Alzheimer's and cognitive change, interested in experts to my right here, but it's clear that the burden of disease in Alzheimer's is greater in women, in large part because they live longer. Do you have any strong sense whether, if you, with age correction, you think there is a significant male-female difference?
I'm told by my statistical colleagues that there isn't, that if you correct by very narrow age strata, that the prevalence is the same, and it's just that women live to be older, and so it appears as if there's a higher risk. But that's what I'm I have to
I
believe them.
never disagree with Marilyn, but I'm going to disagree on this one slightly, only because I think there's very interesting genetic data. So if you're a female and you have one of these risk factors, apolipoprotein E4, which is a younger age gene, you are more than twice as likely to develop Alzheimer's disease. And in fact, there's new data suggesting you're more than twice as likely to have amyloid at a given age. So I think there is some gender interaction with other genes that is above and beyond the lifespan. So it's a double hit, I think, for women.
Selectively in the ApoE4 bearing individuals.
Yes, so this is one gene interaction, but there's also, even in the presenilin 1, there's some evidence that the females are more, but less so because it's mostly postmenopausal women that seem to be at risk.
All right, the last question, sorry. Can't sneak in on me. Go ahead.
It's a very naive question. Do people with dementia know that they have dementia? And if so, can't you just ask people before they have dementia, do you feel like you're on the verge of being demented? Whatever that feels like?
So
Why is it so hard to diagnose?
That's a very good question. In general, when people are beginning to have difficulty, they are aware of it and they complain of it. And as they get more impaired, in general, they tend to lose insight. So we have, both of Risa and I have studies where we follow people longitudinally, and we see repeatedly that when people have very, very mild difficulty, they're completely aware of it. And when it becomes worse, they are less aware. The big problem, the reason it's so difficult to diagnose, is that lots of people sense age-related changes in themselves. And they'll come and they'll say that they have difficulty, and it doesn't mean that they're on the trajectory of developing cognitive decline.
Great. Well, this has been fabulous. So let's thank our colleagues. What a wonderful session. And I just want to thank our colleagues from the Dana Foundation again for their partnership. Thank all of you. Don't drink too much. It's not going to help you.